Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode 197 of the Better Health Guy blogcast series. Today's guest is Dr. Eboni Cornish, and the topic of the show is toxoplasmosis. Dr. Eboni Cornish is a highly regarded physician and provides integrative medicine services to a diverse global patient community. Currently serving as the functional medicine director of the Amen Clinic East Coast Division, she specializes in autoimmune diseases, Lyme disease, environmental toxicity, gut imbalances, neurology, and various other chronic conditions. Employing a holistic approach, Dr. Cornish identifies the root causes of health issues within the body's biological systems, offering comprehensive treatment to adults and children. Her treatment philosophy is integrative and evidence-based. Within Amen Clinics, Dr. Cornish has been instrumental in developing the Neuroinflammatory Intensive program, a 2-week inpatient initiative addressing neurological complications arising from chronic infectious diseases, Lyme disease, mold illness, and other chronic inflammatory conditions, including SPECT imaging. Dr. Cornish's educational journey includes earning honors at Brown University for her undergraduate studies and obtaining her medical degree from Brown University Medical School. She further refined her skills through a family medicine residency at Georgetown University. As a Howard Hughes Medical Fellow, Dr. Cornish conducted translational research at the National Human Genome Research Institute, NIH, working under Francis Collins. She currently serves as the treasurer of the board for the International Lyme and Associated Diseases Society and a fellow of the Institute of Functional Medicine. And now my interview with Dr. Eboni Cornish. I have been wanting to do a show on toxoplasmosis for quite some time, and now thanks to Dr. Eboni Cornish, today is that day. We also had an excellent talk on Morgellons back in episode 112, if you'd like to check that out. Thanks so much for being here, Dr. Cornish.
Thank you so much, Scott, for inviting me. I always look forward to talking to you.
Talk to us about what you see clinically in your patients with toxoplasmosis, the condition caused by Toxoplasma gondii. My observation over the years has been that people that have Lyme disease, but also maybe have toxoplasma, often seem to be more chronically ill, some of them more significantly ill than those without toxoplasmosis. So what symptoms do you observe in patients with toxoplasma? And are the symptoms more physical or more psychological in presentation?
So it's for my patient panel, I have quite a few patients, right? I test for it regularly on LabCorp for any of my patients who present with symptoms or a previous diagnosis, vector-borne illness or chronic infections. So it's kind of a standard test in my panel now because I find it's missed so often. But the thing is, Scott, toxoplasmosis, you don't have to have symptoms at all consistent with this in parasites. So it like ranges. So I have some patients who may have just the regular brain fog, joint pain, some cognitive issues that are mild, who might be coming to me to get worked up for chronic neuroinflammation. And then I test them for toxoplasmosis and they're positive. Or the other patient might be someone who's been treated by, 9, 10 doctors, been suffering from really debilitating chronic vector-borne disease with severe symptoms, and then that is what is the missing link. So I find it more of doing my detective work than having that classical clinical presentation, because it does vary widely from patient to patient.
So some of the things that I've read that can happen with toxoplasma are hallucinations, sleep issues, mood swings, irritability, impulsiveness, OCD, paranoia, unusual depression, panic attacks, ADD, ADHD, rage, depression, substance abuse. Sounds like a lot of those are somewhat psychological, that maybe people would perceive some of those symptoms as more mental, emotional, when in fact they do have an underlying microbial trigger. Would you agree that in many cases there are some of these mental, emotional seeming symptoms?
I definitely agree with that. I would say about 60% of my patients, because I work at the Amen Clinic and we do focus on brain SPECT imaging and integrative psychiatry, a lot of my referrals who have some of those debilitating chronic neuropsychiatric symptoms can have this underlying infection, especially those patients who have kind of severe schizophrenia, because that's what the literature shows. A lot of patients have schizophrenia. And I'll never forget, that was my first toxoplasmosis patient who presented, who had schizophrenia and had been on like 8 different meds and had been hospitalized numerous times. And it was unfortunate because it was just, okay. And he was 20 years old, Scott. And when we did his toxoplasmosis testing, his IgM as well as IgG were positive. So when I'm thinking about neuropsychiatric manifestations that are resistant, but also in combination with brain scan imaging, if I do have that access, that's more what we call inflammatory or toxic. I definitely put vector-borne illness and toxoplasmosis very high on my list.
So you mentioned that you've seen this so often that you now just test for it very commonly. Are there any clues that might lead you to think about testing for toxoplasma or even other parasitic infections in a patient? When do you clinically start thinking about this possibility? Are there certain things maybe in their history or how they're presenting that lead you to think, oh, this is high on my list of things to rule out?
So most commonly, those cats, right? Cats, they're not my favorite. Sorry, cat people, because they can carry both, Bartonella, and cat scratch, as well as toxoplasma. So pets is always one of my questions. Also, patients who I ask a lot about diet, because toxoplasmosis is transmitted a lot in pork. So those patients who have a lot of pork or beef in their diet, those patients, as I alluded to earlier, who have those neuropsychiatric symptoms that just don't get better, or they're treatment resistant, or maybe even just on numerous meds and not adequately, contained with their mood, I'll test them for that as well. And then, some patients would think of travel, especially because I see so many different parasitic infections. Toxoplasma is just one of many. So you always ask about travel. You always ask about lifestyle, because I'll see that quite a bit, as well as pets, diet. And then because toxoplasma is so prevalent and severe in those who are immunocompromised, you worry about that as well. Those who you test their immunity and they have more of a compromised state, you put that on the list too. And then kids with visual issues, because that's one of the things we screen for when we're pregnant. It's the T in what we call torch infections, it's toxoplasmosis. So we routinely are screened for it. So when I see children in visual issues or things like that, I think of toxoplasma as well.
So you mentioned schizophrenia being one condition where you might think about exploring toxoplasma. What are some other conditions? Can it contribute to neurologic or neurodegenerative conditions like maybe Alzheimer's or Parkinson's, or even a contribution to ALS, for example?
It's interesting because it is so neuroinflammatory, at least the patients that I have seen, right? A lot of frontal temporal dementia has been associated with my toxoplasmosis patients. A lot of problems with executive functioning. I have seen one case, which was wonderful and very interesting, because I think all of this is so cool. They had been diagnosed with Parkinson's, and they were found to have both IgM and toxoplasmosis and Babesia fish positive simultaneously. So there's definitely a contributing factor from this parasite, which is intracellular, to those neurodegenerative diseases. So Parkinsonian features. I've had patients who've been misdiagnosed with multiple sclerosis, and toxoplasmosis has been a part of their symptom complex, and definitely lack of executive function. in temporal lobe dysfunction, frontal lobe. So lack of that exactly, which can lead to more of a dementia state where you do lose some of your ADL. So it's very bad. It's very severe, and it crosses the blood-brain barrier.
Yeah, I mean, there was another famous person this week that was diagnosed with frontotemporal dementia. You wonder if they were to get to someone like you, how often might we find some of these things? I suspect it would be fairly common.
Definitely is, and it's so unfortunate that it's missed, in these cases, because you always ask, especially when they're younger, like, what's the etiology? So I get patients and that's the beauty of knowing neurological disease, especially toxoplasmosis, parasites, vector-borne illnesses, because it can be the root cause of neuroinflammation. And then it gets to the point where you're like, oh man, I wish they would have got tested. I wish I would have caught it, because it can lead to a lot of these symptom complex, and it's unfortunate when people miss chronic infections. It's so unfortunate.
Yeah, and I wish more people were looking at parasites. My mentors in this realm have primarily been Dr. Dietrich Klinghardt and Dr. Simon Yu, and they place a lot of emphasis on parasites. And then there's other mentors of mine that I think are also brilliant, but that don't really give a lot of consideration to parasites in general as contributors to chronic illness. And so I think sometimes this idea that, well, if we haven't been out of the US, we're not going to have parasites. I mean, I think we know that's at this point somewhat laughable in my thought process, at least.
I agree with you. And it's so funny you mentioned Simon Yu, who I learned a lot about parasites from. And he taught me a lot about parasites in the oral cavity and foreign dental materials, and just looking at the helminths and the liver flukes and toxoplasmosis in these cases, because it is so common. I would say a majority of us probably have some sort of parasitic involvement in our microbiome, right? But it's just, you have to understand like what patients are going to be more susceptible to systemic parasitic involvement versus others. And I'm always telling colleagues and patients that parasites are a lot of times the missing link. It's not something you'll see visual. People think of that, but they're also takes a lot of work to treat it. I thought when I got in Lyme, 12 years ago, I was like, oh, this is the hardest thing I've ever done. Vector-borne diseases. Oh gosh. And then it became, oh my God, I hate mold and yeast and that. So this is so hard. And then you start looking, and then you're looking, and then you're like, oops, now I opened the can of worms of parasites. And that's completely changed my practice, right? Because they can be that key feature in so many people. I mean, I can't tell you how many people have been to other, got really good diagnostic workups. I mean, wonderful workups. And it's like, oops, parasites missing. And I think it's because of the lack of testing we have for a lot of these parasites, including that good testing for toxoplasmosis, among others, that cause that problem.
So let's talk a little bit about the prevalence of toxoplasma. Is it common? Is it rare? Is it more common in certain parts of the world than others? And then in your patient population, approximately of those that you test, approximately how often would you say you do find confirmation of toxoplasma?
It's so common. It's more than 40 million people in the US have this. And it's the most commonly, even from the CDC, misdiagnosed or parasite out there. It's just prevalent. And that's why I was alluding to it earlier, because it's important for listeners to understand that you can have a range of symptoms from being asymptomatic to having, these debilitating neurodegenerative states, as we're referring to. It ranges across the board. And in my patient practice, I can't quantify, but I know it's a lot of them, especially when I first started screening in my resistant patients who I was treating for vector-borne, for mold, for tick bites, for everything, environmental toxins, and they just were still stuck. They were still quite there. Then I started transitioning a lot more into looking at parasites. So it's very common.
So Toxoplasma is a protozoan parasite as compared to worms or helminths or nematodes. This is a very small protozoan organism, can be a key contributor to chronic illness. Why do you think we don't hear more about this? Do you think that conventional allopathic medicine does give it the attention that it rightfully deserves or needs? And then even in the functional and integrative world, it seems like it's also somewhat overlooked, that maybe it's downplayed or not really explored. Any thoughts on why we don't hear more about or look more for toxoplasma?
In general, I think that when you do hear about toxoplasmosis, it's more focused in the allopathic community to HIV, or those who are AIDS or those who have really compromised immunity. And because it's so common, the thought process, even some of my colleagues, it's like, well, people have it and they'll be okay. Why even worry about it? They're fine. They're asymptomatic, leave it alone. Kind of the same way some people think about chronic vector-borne diseases, Lyme and co-infections. Oh, we're not going to test about it. People, and then they come and then they progress to a more critical state. And I also think, functional medicine, it's tough because I'll tell you something. When it comes to the testing, there's the LabCorp Quest where you can look at antibodies, right? And you can look at IgG, IgM, and you can also look at PCR. Well, I rarely get a PCR test. And I'm lucky if I find an IgM test. So you get a lot of IgGs. And I know there are other diagnostic labs like Galaxy that looks at toxoplasmosis. Vibrant Labs is looking more at toxoplasmosis. There are other companies out there, but it's just not a lot of quality testing for it. And in the past, it was really difficult to get commercial treatment for it with Daraprim. But I am like the biggest toxoplasma app cheerleader out there about testing for this organism.
So let's talk about how people acquire toxoplasma. Can it be passed from person to person? Is it transmitted potentially by vectors like ticks? If a pregnant mom has toxoplasma, can that then be transmitted to the fetus congenitally? How are we acquiring toxoplasma?
All of the above. So let's talk about it. So with cats, and cat litter, stool from cats, you can transmit it from pork and beef. It can be transmitted also across the placenta. So you're absolutely right. And that's why we screen for it, because it can cause a very serious neurological complication and visual problems in the infant as well. Blood transfusions have been associated with transmission of toxoplasmosis. And then it was interesting because I was preparing for a talk on toxoplasmosis. I said, let's see if it's in ticks. And sure enough, I found this paper out of Europe in 1989 showing that toxoplasmosis could be transmitted by tick-borne vector. I was, oh man, here we go. We got another one we should be looking at when we're thinking of vector-borne disease complex. We should put that on the list. But it's very common and easy to be transmitted through those sources.
And it's interesting too, because things that we think of as healthy, like food, vegetables, water, my understanding is we can acquire toxoplasma through those as well. And I read in one place that it's a leading cause of death from foodborne illness, which I really had never thought of. So do you think that food and water are sources where we commonly acquire toxoplasma as well?
Yeah, because a lot of things, anything you eat can be contaminated, not only with toxoplasmosis, but with any of these, intracellular parasites, helminths, flukes. Poor hygiene, can be transmitted, these organisms, but definitely the food and the water. And that's why I said screening for diet is very important, because it's so easy transmittable from these things.
In cases of congenital transmission, you mentioned sometimes you see visual issues. How might that affect fetal neurodevelopment or neurodevelopment of the child and potentially contribute to conditions like autism or like PANS, for example?
So they show in the literature that toxoplasmosis has been associated with neurodegeneration in children. And I think if you think of the science behind it, this is an intracellular protozoa, and it's going to cross into the blood-brain border, even if it's transmitted from mom to fetus. So you already have that risk of neuroinflammation, right? And we know that anything that's potentially neuroinflammatory can cause your body to create these autoantibodies in the nervous system, which as referred to like PANS, like a pediatric autoimmune process. That's definitely something that I've seen in these patients. Also, developmental delays, looking for those milestones that might be delayed. I haven't seen a lot of literature on autism, but I've definitely seen a lot of information out there on developmental delays, kind of cognitive impairment in children, and the visual component, which makes a lot of sense.
So at the risk of not being welcomed by the cat lovers, let's talk a little bit about cats as a source of infection.
I love you guys.
So should people be getting their cats tested? If the exposure was the pet, should the pet be treated? Can we clear toxoplasma in a cat so that it's no longer a potential reservoir or source of ongoing exposure? What are your thoughts on how to manage that cat situation? Can a kitten be born with toxoplasma? Is it only outdoor cats, or can indoor cats be a source of exposure? I mean, we talk about kitty litter, so I'm assuming it's indoor cats as well. But talk to us a little bit about how we manage this potential exposure from cats that can be sources of toxoplasma, and as you mentioned, Bartonella and other infections as well.
So here's the good thing, my lovely cat lovers, is that you can't get toxoplasmosis transmitted from your cat from their fur, right? So that's good. So petting your cat, it's fine. But you do get a lot of transmission, like I said, from those cat litter boxes. And cats can transmit it in utero as well. We know that, rodents can have toxoplasmosis, birds, whenever they ingest one of those infected oocytes, they'll be able to transmit this infection for at least 2 weeks after exposure or more. So that is very important to understand. So it's also known that the cats definitely share that parasite, toxoplasmosis, 2 weeks after exposure. So it's transmitted, rodents, birds, cats, and it can cross the placenta. I would recommend, if you're someone who has chronic illness, right? You have neurological changes, you've been tested. All of my patients who have cats who've been tested positive for toxoplasma, I have them get their pets checked. I have them go to the veterinarian, at least get their antibodies checked, because yes, they can be treated, but I would test if that was your symptom complex, because you could be getting exposed at home and reinfected.
Let's talk a little bit about the life cycle of toxoplasma. You just mentioned a few of the animals that can be impacted. Are there different hosts for the organism? Does it move from one type of animal to another? What's that life cycle that keeps the toxoplasma moving?
And that's a great question. So definitely it can be transmitted from cats, but also from pigs, cows, birds, rodents. It was interesting. I had a patient, this was about 4 years ago, and I think this might have been an anomaly, but they had a hamster, a little boy, and he was testing positive for IgG. And his mom was a veterinarian. She was like, I think I'm going to test this. I was like, okay. But then I started reading mice can transmit Toxoplasmosis gondii. So you get transmitted, it transmits to the host, and then the host sheds the organism. It's like a circular life cycle that occurs. But there are several different hosts out there that can transmit.
And am I remembering correctly that the organism itself can change how the host behaves? So, for example, if a mouse has toxoplasma, they then may not be scared of the cat, and the cat then eats the mouse and then can also acquire toxoplasma, or did I make that up?
No, you didn't make that up. I mean, that's absolutely right. And I think if we go back to what we're talking about earlier about its ability to impact the mood, impact neuroinflammation, I mean, who's to say? And we don't have evidence for that, but let's think of the logic. Who's to say that doesn't also happen in these other hosts, right? So, maybe that could be a component to that response, which would make sense. So that's why it could be one of the reasons why it's so prevalent as well.
Where in the body does Toxoplasma live? I think when we hear parasites, most people think of that as being in the gastrointestinal tract, even though many parasites can go other places in the body. So is Toxoplasma found in the gut? Is it more commonly found in the brain, as you alluded to, other body compartments or locations where it's kind of sequestered? Where does it tend to live in the body?
So it lives numerous different places. So definitely in the gut, in the central nervous system, cardiovascular, then some toxoplasmosis, carditis. We talked a little bit about the eyes, right? Even though that we think that's one of those protected areas, but the fact that it can cause ocular difficulty, neuritis. And again, I was like, oh, how does it skin? So it can be found numerous areas. And that's why I was saying earlier, the misconception when you say that word parasite is that visual stool look and, or you're looking at for worms, pinworms, ropeworms, etc. But this is a intracellular organism because it can basically exist anywhere, right?
We talked a little bit about blood transfusion. So, what do we think the risk is of acquiring toxoplasma from a blood transfusion? Is it something that the blood banks are testing for and have good tests where they can screen and make sure that that blood isn't getting into the blood supply? And then, any thoughts about organ transplantation? Is that a potential source for toxoplasma exposure?
It would seem as if, like we said, going back to just basic science, that it can be in any of these intracellular erythrocytic organisms, protozoa, to be able to be transmitted, right? We just don't have great tests for toxoplasmosis. And when they do test when they're doing blood screening, that is not one that I've seen on the list, even though it's something we screen the mom for during pregnancy, because that's the kind of what's repeated in the literature is cross placenta. But you would think, well, okay, that's an organ, a uterus, right? So why wouldn't it be transmitted with others? So, but it's not something commonly that's unfortunate screened for. And the blood transfusion transmission is very low from what they report. So, which is debatable, right? But that's what they don't support a lot. They don't have a lot of evidence showing that right now.
So, talking a little bit about testing, you talked about IgM, IgG testing. I find, unfortunately, immunoglobulin-based testing for a lot of these chronic infections to be just really difficult, right? Many practitioners, if they saw an IgG for toxoplasma, they would say, well, you had it in the past, but the fact that you're still chronically ill, that's unrelated, which may not always be the case. Do you use IgA testing at all? Is there a place for the immunoblot or ELISA testing? And if someone has only IgG positivity, but clinically fits the toxoplasma picture, would you consider treating them based on IgG alone?
So let's first start with that last question. I look at toxoplasma IgG the same way I look at vector-borne diseases, because we know that in the literature, and this was published years ago in the 80s, that toxoplasmosis can still be active in those who have that IgG presentation. And so, just like with vector-borne illnesses. So I treat everyone with that. And it's so important to also understand that because some of the treatment, the mainstay published treatment, Daraprim, pyrimethamine for toxoplasma is so expensive. It's like $1,000 a pill. However, there are charity pharmacies out there that will, if a provider sends a positive IgG test, can potentially get it covered for that patient because that's significant serology. So IgG, 100% of the times, with those clinical presentations, I will treat my patients, even if it's herbal or prescription, depending on how severe their symptomology is, they're always treated in my practice. PCR, IgA, I test for it. It's hit or miss. I rarely get a PCR positive, Like I said earlier, Galaxy Lab is like one of the only ones I know looking at doing more cellular staining and DNA for toxoplasmosis. But there's really, like you said, with the testing, not a lot out there. But I would recommend that as we're clinicians, right? And we say that all the time when we're treating these complex illnesses, you have to look at the patient clinically. And you have a patient who has these neurological symptoms, these neuropsychiatric symptoms. You've tried a lot of other things. I know a lot of your listeners treat complex illnesses and you're treating them for Lyme, Morgellons, mold, mast cells, and they're still not there. You need to look at it. And if you see that IgG in that symptom complex and the person is still clinically presenting with neurological changes, I would definitely treat in some form. You do not want to ignore it. And it's also interesting, Scott, because another thing I do, because the testing is so limited, that I have found very helpful is that when I get the IgG serology, I track it. And a lot of times, not every time, but a lot, I would say in 70% of my patients, and I have over 200 toxoplasma patients over the years, I find that there's a trend associated with their clinical presentation, which is unique. So, like with Epstein-Barr testing, a lot of times we'll do the serology and we might get greater than 600, for the IgG or BCAs, that's just like the cutoff. And the same thing holds true for toxoplasma IgG. Greater than 400 is the cutoff. And I'll find myself tracking that, and I see the labs fluctuate. All right. I see patients go into normal ranges. I see patients who might present after I put them on like a biofilm protocol or a heavy metal chelating agents, and the numbers shoot back up. And that's consistent with, biofilm. So it's really cool that this is an organism, even though it's limited data, that I have seen and I recommend testing for, and I recommend tracking it based on the symptom complex, but not only that, based on what you're giving the patient, because I do see trends, which is great.
So coming back to our discussion then on pregnancy, would a child that had in utero transmission of toxoplasma, would they even develop antibodies over time to the infection, since it's really not something that they would perceive as foreign? Or would the antibodies from the mom be present at the time that the child is born? Can we test amniotic fluid, for example, for the potential of congenital transmission? How do we explore this in young people?
That's an excellent question that I've been trying to answer, and I get different perspectives all the time. I've had patients who have had, moms who have had tested positive for toxoplasmosis, and then they've gotten pregnant and it's shown up on their torch test. They have tested the amniotic fluid, they've tested cord blood, but then it's like, okay, it's debatable if it's kind of the mom's antibodies or that from the child. I think the best way to approach it is to do the testing. If there's a mother who has a toxoplasmosis, to do the cord testing, to do the amniotic fluid testing and see what it shows. And also to check the child later, if you're seeing those symptoms for antibodies. But, it's mixed. And that's the challenge. Toxoplasmosis, because it's so debilitating and involves the neurological system, it's just so tough because we do not have the great evidence and testing to support what we see both clinically and what would make sense scientifically. And even like I said earlier, looking at immunoglobulins, who looks at immunoglobulins and checks levels? Like conceptually, it just doesn't make sense. You got to understand molecular biology. It just doesn't make sense. And that's unfortunately most of the only things you have out there, right? For this debilitating illness. And that makes it challenging, both for the provider and the patient as well.
So expanding on testing a little bit more, one of the things that you're known for at Amen Clinics is SPECT scans. Are there certain patterns that are commonly observed on a SPECT scan in someone with toxoplasma? And then do those patterns resolve with treatment and retesting?
This is why I love looking at the brain, because, when I started getting at the SPECT scan imaging, it's kind of like oh, I'm treating neurological X, neurological Lyme, neurological, and then I wasn't looking. So you really won't know until you look. And what for our listeners, what SPECT scan does, it's brain scan imaging. It looks at what part of the brain is working too much, what's not working enough, where the blood flow needs assistance, and it can screen things like toxicity, chronic infections, mood and this instability and the like. So it tells you more what questions to ask in the anatomy of the brain. And more importantly, it tells you in my world, kind of, the way I got introduced to Amen Clinic was because they would send patients who had what we call toxic brain scans and didn't know the etiology because they function, most of the doctors in functional psychiatry. So they would have patients like a toxoplasmosis patient or a Lyme patient who would present with treatment resistant mood instability and say, hey, what's going on with this scan? So in toxoplasmosis, what you will see changes in activity. There's something that we call scalloping that you can see on the skull, which is an inflammatory process due to decreased activity of the brain. We also look at blood flow and activity. So in some of the cases, which is really cool, you'll see what we call the deep limbic system in overdrive and the basal ganglia, which is part of that deep limbic system, which can, keep you in that fight or flight, keep you more anxious. And I see that a lot, hyperactive in schizophrenia and ADD, ADHD and anxiety, all of which, toxoplasmosis and other neurological infections like vector-borne illnesses I've been associated with. And when you see that limbic system involvement, when you see that what we call scalloping, that's showing there's changes in both activity, a lot of times I might see what we call the frontal lobes or temporal lobes, which give us that executive functioning being impaired as well with both activity. And you want to get those going. So it's more what we call an inflammatory presentation that you can see. And we call it hypoperfusion, meaning not enough blood getting where it needs to go. We call it limbic system or overactivity, too much activity in certain places. And, when it comes to mast cell activation, I see a lot of that with toxoplasmosis. And when I was doing some digging, I found that there's a high amount of mast cells located in the basal ganglia. Just about when I get brain scans, a majority of my toxoplasma patients have hyperactivity in the basal ganglia region, just like a lot of my PANS kids, some of my Lyme patients. But that's definitely an area of interest for me, is looking at neurological involvement of infections like toxoplasmosis and others on the basal ganglia. So you do see specific patterns there.
And when you then treat for toxoplasma and do another SPECT scan, do you often then see resolution of those patterns that you observed previously?
Yeah, we see improvement, but the coolest thing is that we're able to see kind of herxing, right? I've seen patients who want to repeat SPECT scans because they feel like I'm taking the treatment and I'm getting worse, right? And so out of curiosity, they want to know what's happening. And we know typically when people take treatment for certain infections like Lyme disease, like toxoplasmosis, you can have that pre-radical inflammatory Herxheimer response where you feel worse before you feel better. And I know I had a patient where I did their brain scan again right in the middle of this flare, and it was lit up what we call like a Christmas tree. I mean, they had this inflammatory process, hyperactivity everywhere, low blood flow. It was just amazing. And that was associated with a Herxheimer. And then you can have improvement. Now, the thing about the SPECT scan is that we're looking for improvement of both inflammation, activity, and blood flow, perfusion. And I do see that when I'm, doing a great job to the best of my ability to get some patients better, we do look at ReSPECT is what we call it. And we see those positive changes. So you can see Herxheimer response and you can see, positive changes, which is really amazing.
I like that. So RESPECT.
There you go. Oh, I'm going to tell them that. I'm going to tell Dr. Amen, like, hey,
Are there some cases of toxoplasma that really are acute, that the body, the immune system can fully clear and eradicate? Or do all cases of toxoplasma become chronic, like some maybe suggest with Bartonella? Once we have it, maybe we continue to have it. Once we think of it as chronic, can we then fully resolve it? Or is it something like Lyme and co-infections where it may require some ongoing attention over time, or some pulsed interventions, or some long-term therapy to really support the regulation of the immune system, as well as to make sure that that organism itself doesn't continue to kind of overgrow?
And that's the interesting thing about these protozoa, these intracellular organisms. One part is that when you get this exposure, their life cycle, if you're able to catch it early enough, I am not sure about complete eradication. I don't think I haven't seen that. I do think that this process, people do better at getting this in remission if you catch it earlier. But unfortunately, with the patient panel that I have, I tend to see patients who are chronically ill, who have been to other providers. So it's very rare that I'll catch a acute or IgM positive toxoplasmosis patient. They're usually, out of the patients I mentioned at earlier, IgG positivity. And I find that maintenance may be important, even if it's like, the person gets better, their symptoms are improving. You want to start weaning off some of the harsher antimicrobials and put them on more herbals. That I feel like a maintenance protocol for, especially for this organism and parasites in general, is very important. So all of my patients, I have them on some sort of prevention and maintenance, because I feel like with chronic disease in general, when your body is under stress, or you get another infection, or you get another exposure to something else, these chronic diseases, these parasites, they can flare back up, So it's the thing is more putting it in remission versus kind of a curative state. You want to, and your immune system is brilliant. A lot of my toxoplasmosis patients, their symptoms get in remission, and they're fine. It's like same thing with my vector-borne illness patient. But you still monitor them because these things can be chronic. And then I'll see people reactivate later. So it's about kind of that maintenance stage with most of these chronic illnesses that your speakers and guests talk about, because you have excellent people on here who are in the trenches, man, and we're treating these complex cases.
So with other parasites, we commonly think of maybe initially treating consistently daily for a reasonable period of time, and then shifting to maybe monthly treatment, for example, around the full moon, the new moon, something like that. Or people maybe are treating 1 week out of the month or 1 month out of the quarter, something like that. Is there kind of a rhythm that you then would get into from a toxoplasma perspective, so they're not necessarily needing to treat every day, but that we still kind of make sure that we're providing enough support to keep things in remission?
And I'm so happy you mentioned the moon cycles, because I'll tell you, and I have to be honest, when I first heard about that, I was like, that mean, that's foo-foo. And that's a functional doctor saying that, right? A Lyme specialist. How dare I think that? And I treat all these complex cases, like, what's wrong with me? But anyway, I make sure that any of my patients who have parasitic infections have been diagnosed, that full moon cycle is covered. Even if it's maintenance, they are taking something during that full moon cycle. I do transition, but once again, like I told you, I'm more clinical, right? If I feel like someone's symptoms are better, their immune system's more robust, they're doing all the right things, they've went through their treatment, they're eating right, they're taking care of their lifestyle, they're not exposed to other things, their immune system is more robust, those are the people that I might put on that kind of full moon only protocol, where they're really aggressive with an herbal regimen during that time of the month. And then others might require that daily regimen. But the thing that's tough about these parasites, Scott, is that there's so many variables that cause difficulty with achieving remission, right? It's not just the bug itself. You ask yourself, well, what keeps it resistant? Which is why parasites become such a challenge in some cases because, they lay their eggs, they reactivate, it's this vicious life cycle, and it's more or less getting this into stability with your immunity. And I find that even with toxoplasma, that's the case, but definitely with a lot of those worms and the helminths, all of these we were mentioning earlier, you have to look at other things. You have to look at biofilm, you have to look at metals, you have to look at environmental toxins, other things, you have to look at mold, those things that can perpetuate disease and compromise your immune system and encourage that more resistant biofilm development. Because I can't tell you a lot of my patients, I would say a lot of them who have parasitic involvement, and even my toxoplasmosis cases, we find that there's also a metal component or a mycotoxin component as well that's compromising. And you think about it, they're immunocompromised, right? So you look at all the other variables, because this is usually most commonly the patients who are symptomatic are those who have a compromised immune system.
Perfect lead into my next question, which is we talked about the fact that toxoplasma is more commonly an issue in someone that is immunosuppressed. Wondering if you find immunosuppression in people that are dealing with mold exposure, for example, or even chronic Lyme disease and the resulting immune dysregulation that comes from that. Are those things, mold and chronic Lyme disease, enough to dysregulate the immune system to open the door for toxoplasma? And if someone has mold exposure and is dealing with toxoplasma, do we have to address the mold exposure to lessen that immune dysregulation, to bring more modulation, more tolerance, more regulation to the immune system? And then building on that, is toxoplasma really ever the only contributor to a patient's chronic illness, or is it generally in the backdrop of many other factors?
You're always so great with your questioning, Scott. I love it.
Neil Nathan tells me they get a little wordy, and I know sometimes they do, but I like to just
we're like, okay, what part? But no, they're always great. I mean, and I think it's important to share this. So when we're thinking about complex chronic illness, and like you alluded to earlier, I'm treasurer of International Lyme Associated Diseases Society, and we actually changed our mission statement to state just that we treat complex chronic conditions. That's what these patients suffer from. I don't think it's ever just one thing, because if it was just one thing, that's probably the person I haven't met. That's the person who has the robust immune system, and that one thing that they were exposed to, lucky enough, it's in remission in some cases, But for a lot of these patients, when they come to our office, just like a lot of your guests, they suffer from so many things at once that are chronically, like I like to think, beating up their immune system. And the analogy I tell my patients is almost like a whack-a-mole, that game where you got the gophers, you hit one thing and something else pops up, and you hit that and something else pops up. And so it's kind of like when you do your detective work, the more you look for, the more you find, and then you have to treat. So with patients who have chronic parasites, also chronic Lyme disease, chronic toxoplasmosis, it is very important that you look at the variables. I tell my patients, the way I phrase it is, I have to find out why you're special. They're like, what does that mean? I said, well, you've had these illnesses, but what makes your symptom complex so resistant and so chronic? And that's going to mean we're going to have to pull back those different layers to adequately get to the meat, to get through to the parasites, to get through to the Lyme, to get through to whatever bugs might be present. So when I'm kind of thinking of a hierarchy, like a trying to titrate or channel and get focused, right? Because it's so easy to take the patient, test for everything under the sun. I typically look at first, before we even get into the mold and the metals and things that compromise their immune system, I start with the basics. How is your sleep? How is your hormones? How is your gut? Because if I can get that stable, get that body stable, when I find other things, that treatment might work better. So I work for like the homeostasis first. Like I really kind of get that because I'm like, well, I can look for these chronic things, but if a person's not sleeping or eating right or constipated or, then it's going to be more of a challenge. So I make sure I'm doing that. And you can simultaneously look for other things. And I find definitely the environment, like you alluded to, water damaged buildings, mycotoxin illness, that is such a barrier to healing in so many patients that suffer from these other chronic inflammatory illnesses. Because you don't remove that barrier, it's kind of like it's more challenging to get rid of other things, the infections. So most of the time, if I don't look for mycotoxin illness, I'm asking about it. That's a part of my screening. What kind of home do you live in? Have you been exposed to mold, tested for mold? And then we do more details. I might have them do VCS testing or something to give me some indication if I should go down that road. Because like I said, the more you test for it, the more you'll find. And then I might also look at, and like I said, other environmental things like metals and the like. And try to look at treatment of that. And then getting down into the bugs. Because like we said, what makes you so special? What symptom complex is there? And a majority of my toxoplasmosis patients have other issues. And maybe some of them might even have other chronic infections. And what I found now, which makes it even more fun for me being a detective, is that you layer on the viruses, things like COVID-19 that we know in public safety can reactivate things like Epstein-Barr. So you layer on those reactivated viruses that's also contributing to this chronic inflammatory process. And you just really have to try to remove one layer at a time. And I think that's what gets tricky, both for patients, because you might get impatient, right? You're like, just treat this one thing. Like so many people, I'm like, just get toxo out of me today. And it's like, but wait, there are other barriers here. We have to find out what makes you special. You got to treat environment. You got to treat you. You got to treat the basics. You got to treat your, and then we can go getting all into the weeds so that it gets better. So definitely multifactorial. And you definitely have to do your detective work and get organized. Because I know a lot of doctors who train with me, because I'm a training doctor for ILAD. So I'll train doctors. They'll see my toxo patients, my Lyme patients, and you should see the look when I finish an appointment. Their eyes are like wide open, and mine probably are as well as the patient. And it's like, well, you just have to take a moment, think of the symptom complex of the patient, and prioritize, because you can't do it all at the same time. But definitely, if they're living in mold and their environment is toxic, then you have to treat that too. You have to.
How often would you say you see someone that has chronic toxoplasma that does not also have mold and mycotoxin issues, or other chronic vector-borne infections, Lyme and co-infections, or maybe now long COVID as well? Is it fairly common that one or more of those is often in the picture as well?
Exactly. And that's why I was saying they're multifactorial, because toxoplasmosis is typically most active clinically in those that have that compromised immunity, right? So there are going to be other things that are going to cause your immune system to be dysfunctional. So a lot of the patients also have vector-borne illness or mold, or like you alluded to, viruses, and maybe even other systemic parasites, that are causing this compromised immunity to occur.
You mentioned mast cell activation syndrome. I tend to think of mast cells as being triggered by mold, by parasites, by EMF exposure. There's a lengthy list. I think in the last couple of years, we have more awareness that Bartonella can be a trigger for mast cells as well. Do you think of toxoplasma as being a primary trigger for mast cell activation as well? And do you work to treat or support the mast cell activation in your patients before you really start getting into more of the antimicrobial therapies?
Yeah, mast cell activation as more of symptom complex due to underlying triggers. So I look at it at the M&Ms, like the candy. So when I think of mast cell activation, I think of mold, multiple infections, and multiple chemicals, because there are so many things that can lead to degranulation of these mast cells. And it's not like it's just histamine, right? It's so many other mediators that these mast cells produce. And I think a lot of times they get an unfair reputation, these mast cells. It's their fault. They're part of our immune system. We need our mast cells to work. They're breaking down because of those triggers. And if something is inflammatory, like Lyme disease, vector-borne illnesses, like yeast, like mold, like parasites, viruses, chemicals, those are going to lead to degranulation of those cells and cause the patient to be more inflamed and more symptomatic. I don't know if I would necessarily say a primary is toxoplasmosis. I think it's a plasmosis. I think a cause of mast cell activation in that kind of M&M process is this toxoplasmosis because of that triggering effect. And we know how debilitating and multi-systemic mast cell activation is, like how it affects just about every system in our body. But because it is an immunocompromising illness and an inflammatory illness, it does trigger that mast cell degranulation in a lot of my patients.
And then do you find stabilizing the mast cells and reducing histamine is a key part of your toxoplasma treatment approach?
Definitely it is. I always tell patients, we're going to use some stabilization. We're going to use some quercetin, some bromelain, some H1H2 receptor, things in the mix. We're definitely going to do that. And that's true for just about all of my patients. Well, I would probably say 95% of my patients who have chronic debilitating illness. There's usually a histamine mast cell component, especially long COVID, and especially with parasites. So it does require that I have a long arsenal of mast cell stabilizing agents. Some things I find, I try to kill, two birds with one stone, especially with my toxoplasmosis patients, because as we discussed earlier, a lot of them have those neurological and neuropsychiatric symptoms, a lot of which can be anxiety. So I might use things like a Vistaril or something that's hydroxyzine that's more calming to anxiety, but it's just a histamine blocker. Or they may have insomnia because we know parasites in general are more active first thing when you wake up and at night. So a lot of parasitic involvement, I might use something like a ketotifen at night to help them not only with their histamine response, but giving them that sedative effect in the evening. So definitely it's warranted. You need to calm that response, but more importantly, you're going to have to treat that trigger that's causing it in the first place. And that's what I think a lot of people miss. They're like, oh, I'm taking all my histamine things and I'm still reacting. I'm like, but wait, do you know what's triggering that? And that's another reason why it's important to look at toxoplasmosis, especially when you're dealing with mast cell activation, because you can be on a numerous amount of stabilization and still have breakthrough triggers. And then toxoplasma is lurking in the weeds, and it needs to be addressed as well.
I totally agree with that. I don't think personally that the mast cell activation is the core issue that makes people unwell. I know some brilliant people do think of it that way. To me, kind of using the analogy that Dr. Horowitz uses about the nails in the foot, if the mast cell activation is kind of the redness and swelling around the nail, well, we can put the arnica cream around the nail, or we can pull the nail out and then put the arnica cream, right? So we got to get the nails out, and then the mast cell activation becomes less of an issue because the triggers, as you mentioned, are no longer there, or at least better supported. When we think about treatment of toxoplasma in general, how much of the treatment approach is antimicrobial versus treating the effects of the parasite, such as reducing neuroinflammation or modulating the branches of the immune system, looking at Th1, Th2, Th17, Treg, all of those things. So at a high level, what are the main components of your treatment approach to toxoplasma?
That's an excellent point. I'm always working on immunomodulating immune support for my patients. So I'm always using things like low-dose naltrexone or SPM active or, dietary restrictions or things to remove inflammation in general to help optimize immunity, gut support. So that's important in my treatment of any chronic infection that we work on immune modulation, because if we don't, the immune system is like a hair trigger, right? And you're going to turn over, and next thing you know, you're going to be dealing with autoimmune disease as well. So I make sure that's a part of my foundation, and that should be for everyone who's treating these chronic conditions, that you build it up. You start at the basics and you build up accordingly. So that's definitely happened. I'm definitely focused on immune modulation as we simultaneously treat that underlying infectious process. So you have to look at what that infection has done, because we're calling it chronic. So what has it done? What has it caused? What has it done to your immune system? And then treating the bug itself. And with toxoplasmosis, as we stated, the treatment was not really commercially available. Like the, Daraprim, it was just hard to get. But now, like I told you, you can get it now with most pharmacies. Some pharmacies are covering it with the serology as well as a charity pharmacy. So I find myself using, and even this is with, Scott, most chronic illnesses, a combination of the prescriptions and the herbals, because I think you need both, and the immune support. So it's like a trifecta that must occur if you want to get this immune system working, so that it can get these diseases in a remission status.
So let's talk more about the pharmaceutical options for toxoplasma. As you've talked about, one of the better known may be Daraprim or pyrimethamine, which was in the news for a while with Martin Shkreli's company charging thousands of dollars for a single pill. Talk to us about Daraprim's place in your treatment of toxoplasma. Is it always a key component, a key go-to in treating toxoplasma, or one of many things that are in your toolbox?
Is one of many things in my toolbox. And unfortunately, because like you said, with that controversy and that unfortunate, oh God, that's like gives me trauma thinking about it. Because I used to give Daraprim a lot and it was $4. And then all that happened. And then now it's $1,000 a pill. But some patients don't qualify for charity, payment, and they can't get it covered by insurance. So over the years, I've had to create so many alternative second and third line protocols just because of lack of access. And then you also have to make sure you're checking labs for a patient. So Daraprim is always used with folinic acid, leucovorin, and you want to make sure you're checking G6PD. I do have a few patients that have toxoplasmosis and are deficient. So that's usually something that's contraindicated, that G6PD and Daraprim. You have to be very careful. But it's an important part of my protocol, and it's an optimal part of my protocol. But at the same time, I've had some benefits with some of the second and third line treatments. Like I've seen a lot of clinical benefits, and I've had to be creative with things like Bactrim or Mepron, clindamycin, ivermectin, and just being strategic in my approach. But on top of that, as we talked about, it's because there are other things, right, going on simultaneously. So I like to use both herbals and antibiotics if I have to, because of, the whole, you want to support the gut. So you want to just abuse it, but it's required in a lot of cases, especially severe illnesses like toxoplasmosis. But you can also kind of treat if the person has babesiosis or Bartonella or Borrelia. You can try to choose some agents that can do both and treat both organisms simultaneously. And that's key. And then I also use a lot of herbal antiparasitics as well, which I think have some place with toxoplasmosis and all parasitic infections.
So what is the general response to Daraprim? Do people have significant Herxheimer reactions? Do they generally just feel better while they're on it? What do you see in your patient population with Daraprim?
So going back to our, mast cell discussion, right? A lot of patients with these parasites, even when you're looking at, eosinophilia and IgE, elevations that you can also see in mast cell, these patients can be sensitive. They've been through a lot of treatment. So you do have to try to find that balance in a lot of my patients who have, parasites, because Daraprim is aggressive. And a lot of these prescription meds are aggressive. And in a person who has a high histamine burden or is already having a high inflammatory burden, you may, in that case, have to go very slowly because of the severity of the potential Herxheimer response. And I see that quite often, I would say in 50% of my patients. So I've learned over the years that I have to be patient with myself and my treatment when I'm using more aggressive agents, because a lot of these patients have other issues. And like you said, that whole nail foot analogy, the histamine response is already elevated, inflammatory response is elevated. So in this case, I try to kind of baby step sometimes. I'll do like trial dosages. As far as the people who are successful enough to take the Daraprim, it can work, and it can work really well in those patients. But as I stated, in some cases, I do go very slowly. I might do once a week or, once every other day. It depends on the case. And definitely with kids, I usually try to do more of an herbal approach or some of the other agents, because I find that Daraprim really doesn't work well as far as tolerability from both a Herxheimer and GI standpoint in my pediatric population. So that's not something I use for kids, just in my practice. And then when you're using some of the other meds that cover it, like the, Mepron, atovaquone, that also covers babesia, you go slowly with that, or clindamycin. You be cautious because clindamycin is really harmful to the gut and can cause C. difficile. So you make sure you're optimizing probiotics as well. So it takes a unique approach. I used to say this was my protocol and that was it, but I find that doesn't work. It's not a one-stop shop for everyone, but people do get better. And like I said, I have some people who are just on herbals. It may take a little longer time because they can't tolerate prescriptions. They're just too sensitive, and it works as well.
How long would the average patient be on Daraprim in terms of their course of treatment? And would you oftentimes start with that as kind of the flagship tool for the treatment of toxoplasma? Or would you sometimes start with weaker interventions and then use Daraprim later in a protocol so that by the time they get there, the burden of toxoplasma has already been reduced in hopes then of increasing tolerance to Daraprim?
So usually I have to wait to introduce Daraprim in the first place because of the insurance issues and needing prior authorization, which is the majority of the cases. So I find myself just in general, it's mandatory that I start with a more gentle approach before I go to Daraprim, just because that's the time it takes. I'm not going to have a patient wait a month or 6 weeks or 2 weeks to start their treatment if we have that diagnosis and they're symptomatic. So ever since the change in price, I've had to start with more gentle agents, which as a result does exactly what you said. It can lower that toxoplasmosis burden so that their tolerability is better. And sometimes I call it kind of like a desensitization, like you start slow and then you build up. And I think that does improve tolerability to Daraprim. Now, not all of my patients require it because it does have complications, especially with the gut. But I think if you can use it, it is very helpful. But also you can use things like Bactrim, atovaquone, clindamycin, alternatives, and herbals that, I'm very passionate about to start with, and as you pace them, or even in lieu of Daraprim if you can't acquire it. People get better with different strategies.
Probably one of my favorite tools in the treatment of toxoplasma has been Alinea. And so I'm curious if you use Alinea at all in treating toxoplasma. And then let's talk maybe a little more about some of the pharmaceutical medications. You've mentioned several of them. I know that from one of your prior presentations, you've also looked at itraconazole, for example, rifampin, doxycycline, dapsone, the macrolides like Biaxin and clarithromycin, for example. So are these having a direct effect on toxoplasma, or are they working on other things that are then helping the body to have more ability to respond to the presence of the toxoplasma? How are some of these other medications, like itraconazole, for example? We usually think of that as antifungal, used in people with mold illness if they have fungal colonization. Where does that fit in the treatment of toxoplasma?
So let's start with itraconazole. Like, I find that, like we said, a lot of my patients with toxoplasma also have mold illness and candidiasis, or different forms of yeast. So I think it's kind of like a microcolony of multiple microbes that exist, with toxoplasma being just one of them. So I have seen some benefit with a lot of different antifungals utilized simultaneously with my toxoplasma protocols. But as far as kind of the gold standard, some of the agents I'll use in my toolbox as I'm creating different protocols, they're definitely Daraprim. I use a lot of atovaquone, Bactrim. I do a lot of clindamycin. I've had to incorporate, I have to, not all at the same time, right? So I don't want any listeners saying, oh my gosh, she uses 30 things. No, but you have to think about the persistent organism and other things that are there. So atovaquone, clindamycin, Bactrim, Daraprim, Alinea, Biltricide, ivermectin. Those are like kind of the core prescriptions that I might use. But do I also get benefits from the antifungals, the macrolides as well? Of course. And I think it's more because I'm also covering for other imbalances and other infections that exist in that individual. So I wouldn't say those would be my first line treatments, but I do think that they help as adjunctive therapy, depending on how you design your protocol for that individual, because it can cover some of the other things that exist.
And do you find that people respond well to Alinea when they're dealing with toxoplasma, or is that not one of your primary tools?
I find that they do respond well. And it is one of my primary tools, especially if I can't get Daraprim coverage or a person can't tolerate Daraprim. I might use atovaquone, clindamycin, sulfalzine, and Alinea, kind of rotating protocols. So it's definitely something that I incorporate and I have a lot of success with. It's sometimes also insurance problems with that as well, but it's definitely something to consider.
Yeah, I'm a big fan. Very few pharmaceutical drugs that I really am a fan of, but Alinea is one of those. And I think in this context, we know it can be helpful for Borrelia, for Babesia, for many parasites, for toxoplasma. So I think it's one of those also hitting multiple birds with one stone, as you mentioned earlier. We've heard a lot in the last couple of years about dapsone from Dr. Richard Horowitz's work. Do we think that dapsone has some direct impact on toxoplasma, or is it more focused on the vector-borne infections?
I haven't had as much success as I thought with dapsone in my toxoplasmosis patients. Now, some of my other populations, like my Morgellons patients, my patients who have Bartonella, Borrelia, even some of the Babesia protocols I use definitely have had some benefits. I've seen a lot of benefits with that, but not as much, with our patients there. And I don't know, like I wouldn't use the Daraprim if someone's getting treated for persistent infections, Borrelia, Bartonella. I would not use Daraprim and dapsone simultaneously due to drug interaction and also their ability to decrease folinic acid, which is why you use the leucovorin. I wouldn't use those together, but I haven't seen as much success with that for toxoplasmosis.
In one of your talks, you mentioned antihelminthics in treating toxoplasma. So we're thinking about things that we normally be considering for larger parasites,
Mm-hmm.
worms, for example, but do they also have anti-protozoal properties? What are some of the anti-parasitics that we think about? So, for example, you've mentioned ivermectin, Alinea.
Mm-hmm.
I don't think we talked
Mm-hmm.
about albendazole, for example,
Mm-hmm.
biltricide, pyrantyl palmate, maybe others. What of the anti-parasitics have worked best in your toxoplasma patients?
So definitely ivermectin and Alinea. They're the top two that I see quite often, tried and true. Biltricide, I've been using more probably in the last 6 months or so because I see it works so well with some of the other helminths. And the more I do stool tests and talk to people, I'm like, oh gosh, I got to make sure I've got that on board as well. And like we say, the more you look, the more you find. So I think that that's had benefit. But I think the top two for your listeners, Alinea and ivermectin, I've had the most success, but I have used the others as well.
That's the ivermectin is the other one of my favorite medications that's available out there.
I think those are really good. I do the antibiotics, but I find myself straying away more or trying to get that get in, get out mentality, right? Because you do need it, right? We have the evidence, and especially some cases they are helpful if you can tolerate it. But when you layer beautiful herbals with it, or kind of get in, get out, that's why I get in with the antibiotics, get out, and then put the herbals on after you've decreased the pathogen load. People do really well. Or homeopathy. I'm a big fan of that as well. So it takes more than one thing. You don't want to abuse the gut too long, but you do need it in a lot of cases.
So that's another great segue. So let's talk about herbs and homeopathy. So what about some of the natural options, like Byron White has one called AT? There's formulas from Beyond Balance, other natural herbal formulations. What are some of the things that you might think about in the herbal realm for toxoplasma? I've read about in research papers things like ginger and wormwood or artemisia, berberine, myrrh, black walnut, oregano, garlic, even some essential oils have been discussed. What are some of the tools in that realm that you find the most clinically helpful?
So definitely oregano oil, that ATP, that's one of the things by biotics research that I love, that I kind of want to have on my list. And then artemisinin. I use artemisinin SOD by Research Nutritionals for my toxoplasma patients. We're looking in, and sometimes I have had, just because they may have had babesiosis as well, patients on cryptolepis. Not a lot of literature on it, but I have had patients on that. A lot of thyme, a lot of wormwood, a lot of berberine. So I have a core group, and I do like parazomin, right? Beyond Balance, that's a great agent. And then another thing in my really big arsenal, is I really like the Cell Core Para 1, 2, 3, and 4. That's a great agent I've used quite a bit in a lot of my parasitic patients that I find helpful with that Mimosa pudica, the thyme, the neem, wormwood, and they are pretty well tolerated. So I have a long toolbox that patients can benefit from, but it definitely is, that's the one thing. We get a bad rep in functional medicine and being Lyme special that we just throw the kitchen sink. So when I'm talking to people, I always say, these are my toolbox. But typically, I'm using as minimal interventions as possible to get you better. You don't want to have supplements, 30. I have patients who come, I'm like, oh my God, you're on 15, 20 things. Who did that? You? Oh, I did it. Sorry. All my patients are like, Dr. Cornish, I have a pharmacy in my house. They get things from doctors, and it's just like so long. So I always try to find a toolbox, and I have the common things I like, and I try to make sure they overlap with other things I'm treating to do the best job I can at minimizing, the pills and supplements they're taking. So that's why when I was listing my arsenal, yes, there are a lot of tools in there, but I do have, an order I try to approach so that I'm not throwing 10, 12 things at one time, because then you don't know the benefit.
You mentioned the Research Nutritionals, artemisinin, and SOD products. So are you generally, when we're talking about wormwood and artemisia, are you generally moving more towards the artemisinin isolate itself, or in some cases, are you using broad spectrum, full spectrum Artemisia, the whole herb?
So, with a lot of patients who are very sensitive, I find myself having to use one herb at a time to really see a response, because if not, the Herxheimer can be very severe. So I do like, starting kind of with single herbals to see if I gain some traction. So that's where the Artemisinin SOD comes in. But then once I find their tolerance is good, then I might layer more of the holistic, comprehensive herbals on there. But I've just found through the years, seeing sicker patients, that trying to give them something that has 6, 7 ingredients, they might not accept it or tolerate it. They may have the die-off reaction. And then it's frustrating because then you have to stop therapy, and work more on a slow approach. So single herbals, I find, to start with things like toxoplasmosis is helpful. And then building as you go, as you find a patient is tolerating it.
In the Lyme conversation, the Bartonella conversation, we've seen more and more use of methylene blue in the treatment of Bartonella specifically over the past several years, since that came out in one of the research papers. Is there a place for methylene blue in the treatment of toxoplasma?
There is actually, but the caveat, like I said, is that I'm treating other things as well. And I see a lot of toxoplasmosis in Bartonella. And I'm starting to question myself, is it the kitty litter connection between the two, or just the vector-borne disease connection? So I'll have a lot of my patients who might be on methylene blue for Bartonella, but it's not one of my primary go-tos for toxoplasmosis if that's my primary organism, but I have seen benefit when treating both.
There are homeopathic products available, such as the Toxoplasmosis nosode from Professional Formulas. There's a number of toxo remedies from DesBio, such as their series kits and their Toxo Homo or Homocord product. Are you using homeopathics in combination either with pharmaceuticals or with herbals in the treatment of toxoplasmosis? And do you find that homeopathics are important in treatment approaches?
I think bottom line, homeopathy is very important in treatment of these complex illnesses. I love it. I have had some benefits over the years, not a lot with the DesBio Toxoplasma protocol. I mean, homeopathy is beautiful. It's usually safer. In some cases, it's not as provoking as some of the more aggressive prescriptions. Good for the gut, good for overall well-being. So I am a big fan of incorporating that in my therapies. I really am. And some of my patients, that's all they can tolerate is from a homeopathic treatment option. They can't tolerate the plants, the herbals, or the prescription. So I love them.
And one of the things that I personally like about the homeopathics that are available for toxoplasma is after maybe you've treated with pharmaceuticals and herbals, and you're talking more than about just kind of keeping the immune system dialed in so that the toxoplasma doesn't become an issue again. Something like a toxoplasma nosode or homocord seems like it can be really nice just to keep reminding the immune system of what it needs to be doing to support us.
Yeah, that's great. I have found benefit with using homeopathy as a maintenance approach, because that's what I talked about earlier was maintenance. And I try as hard as possible to transition people when they go through the treatments to more of a maintenance with homeopathy or herbals, just to keep their immune system more robust. But I always tell patients, I'm an MD, but if I could be an MD secretly, I try to play one on TV that might not be real, but I have some value there. So call me an MD, I guess.
I love that. So let's talk a little bit about biofilms. You mentioned earlier that sometimes the biofilm work is a part of your treatment. How often in people with these chronic infections do you find you have to support the biofilm component? And kind of where I'm going with this is sometimes that is the most difficult aspect of treatment, right? You start treating biofilms, basically bringing out these sequestered organisms and metals and all of these things. And you can really trigger mast cells. You can trigger immune dysregulation. I mean, I've been through this myself. Sometimes the biofilm therapies, you can release a whole bunch of viruses or other co-infections. And so that process itself is usually unpleasant. So talk to me a little bit about where biofilms fit in your treatment model, and is it something that all of your patients need to do?
So I think that it's very important in a majority of my chronic patients. But as you alluded to, it can be very provoking and stimulate that histamine response, which is why I think a lot of people have such severe Herxheimer responses with it. But I have to make sure I have proper drainage on board, proper detox on board, that we kind of limit some of the other toxic exposures that already cause this inflammatory state. So it's like we're not adding as much fuel to the fire. I think it might have been Christine Gedrich years ago. I heard her analogy about the faucet and the drain, and that just like stuck with me. It's like you got to have that faucet open before you turn on that drain, or you're going to have a flood, And I think that analogy holds true when you're treating these infections, right? You poke the ugly beast, which is that biofilm that I always say was just, living there, invading the immune system, happy that it wasn't being recognized, not in this planktonic active state, having their little house party because it's a microcolony of multiple different microbes. And then you start opening them because you need to. I mean, some of these intracellular organisms, especially babesiosis and parasites and, sometimes even Bartonella and definitely toxoplasmosis, you have to try to get into that parasitic component. So it's about preparing them for that and taking it slow. So I find there's a great need for fibrinolytics like balut, or what's called lumbrokinase or serrapeptase or nanokinase, and sometimes even Flagyl Tindamax, just to really get into that biofilm, but keeping in mind that like you're going to poke that ugly beast and other things are going to be present. And that's why it's important that you lower that toxic burden as much as you can, right? Because you're going to be waking up things that you may not have known were there, like the whack-a-mole. Things are going to pop out and you're going to get shocked, right? So you just have to prepare the patient. Don't rush, right? We all want the victory and we want to go hard and go home, but that's not how you treat this, because sometimes that inflammatory process can take you backwards. And I learned that the hard way. It was like, push through. Yay, you can do it. You can do it. And then next thing you know, it's like, oh, wait, you're so inflamed. We're back at square one because these bugs love a hostile environment. Or, oh, wait, I've done all this and you're breathing mold every day. Oops, sorry. Oh, wait, you also have yeast in there and, you have viruses and I didn't know. So it's really about getting the right detox strategies and drainage and not just a kill. You got to detox and filter out things as much as you kill, especially when you go into those biofilms, because that's a whole nother animal, those biofilms.
I've definitely learned in large part from my mentoring with Dr. Raj Patel that a lot of times the body responds better to those interventions that are feathers rather than those that are sledgehammers. And I think you're kind of saying the same thing. I mean, there may be a place and a time where we need something bigger than a feather, but sometimes those sledgehammers, they leave a lot of collateral damage behind. I certainly have experienced that over the years. The other thing I guess I would say is if you're going to use words like drainage, I think you do need to give your MD card back, because now you've really crossed over. I mean, you're going to start talking about extracellular matrix and those things pretty soon. And then I know you're really in the land of the naturopaths, which is my...
That's one of my favorite things to talk about.
That's my thing.
Matrix.
Yeah.
Oh man, I'll give it up. I'll give it up, guys. I've been asked to give it up for a long time. Just call me ND, Eboni Cornish. Maybe I could be an ND, MD. I just wish that's what I secretly want to be. I wish I was an MD, ND, and I had time, if I didn't have these triplets, to go back and be a naturopath and learn more. But I just learned it because brilliant things like what you do and brilliant conferences and brilliant people. Because NDs, naturopath, it's the way to go. If you're closing your mind, man, you can't treat these things. Get out of here, So sorry, sorry, MDs. I'm an ND now.
So one of the tools that I know as an MD is not something that is readily used is talking about the realm of frequency medicine, Rife instruments, the Spooky 2, the Nicky, the Wave 1, all of these kinds of things. And so I'm wondering, in your patients with toxoplasma or other chronic infections, do you find that there's a place for more frequency, more energy medicine that can also be helpful in supporting their recovery?
About the concept, right? Any organism that enters your body is going to change the energy. It's gonna alter that. So I think there is a place for it, right? I'm still, I see other people who do it and I've had mixed results. That's not something, I've incorporated yet. So I don't know if I have to give my ND card back just for that. But I think ideally the concept, there's a place for it because it just makes sense. If you're changing the energy in your body because you have all of these foreign microbes in it, there may be a place to use energy medicine to treat it. So I just haven't incorporated. I have colleagues I collaborate who have, but I'm open. I'm open to learning as long as it makes you better and it's not too off or too harmful. I think there might be a place in it. And I know there are a lot of well respected people who do it.
And to some extent, homeopathy is kind of crossing into the energy medicine realm anyway, particularly when you get to certain dilutions that are,
yes,
working much more in the energetic realm already. There is some discussion about toxoplasma being involved in calcifications in the body, particularly in the brain. So do we need to explore and address calcifications independently of treating the infection itself?
That's an excellent question. And I know a lot of that literature on calcifications and toxoplasmosis is from the HIV literature. That's where I've seen it the most. And I think it does hold true. On the SPECT scan, we don't necessarily look for the calcifications per se, but have I seen that in toxoplasmosis cases? Yes. And then, a lot of my patients are already on things like, vitamin DK, or some can even be on bisphosphonates if they have, issues that can lower calcium. But I measure that in everyone, looking at calcifications is not something I'll look at neurologically with people, but, looking for risk of development because it's so prevalent, not only just in this neurological parasite, but in dementia and other neurological diseases. So I definitely think it's a place for that. And that's something that can be considered for treatment.
There has been some recent work done on immunotherapy for toxoplasma at Johns Hopkins that targets the PD-1 pathway and alleviates the neuroinflammation that's caused by toxoplasma. Wondering if you have any thoughts on that intervention, that approach, and is anything in that realm currently available or in the near future potentially available for human use?
Yeah, I thought that was cool. The paper and so unique because like I said, I think about things very simply. It's like, yeah, if you're doing a PD-1, intervention, you're telling the T cells to wake up and shift and stop it, kind of get organized, target this underlying infection and not the host, And I think that definitely makes sense because a lot of my patients have so much Th1, Th17 or T cell dysregularity that would be appropriate. I haven't used it yet. I can see that there will be a lot of drugs down the pipeline. Some of the ones that I'm more familiar with are those that are used for cancer, but I haven't incorporated that in my practice. But the concept, because I'm such a nerd, it was so wonderful when I heard about it. It just makes sense. So when it is available, will I use it? Well, it's probably out there. Have I used it? Not yet. But I think once again, there's probably a lot of smart people using it and getting great results.
You mentioned earlier that one of the things that you can see on the SPECT scanning is this limbic system dysregulation. Wondering if you've observed a place for some of the limbic system retraining programs like DNRS, like the Gupta program, like Primal Trust, and do you see shifts in brain scans when people are doing that type of work?
Oh, yeah. I don't know if this is going to be giving my card back, but I know with limbic retraining, it's so important. And even at the clinic, we do a lot of talking about that at Amen Clinic. Dr. Amen is a big fan of EMDR. We use a lot of biofeedback. I am very familiar with Annie Hopper's work. I'm a big fan, of limbic retraining. I know we use at Amen Clinic a lot of EMDR. I know Dr. Amen's a big fan of that. I have done a lot of research, and we even had a doc call with Annie Hopper, which was fascinating, where she spoke to all the psychiatrists on a call about the importance of limbic retraining. And I learned first about it with Neil Nathan when he was doing his talks on cell danger response. And once again, things when I hear them, they make sense. And I think maybe because I was a researcher, that was kind of how I transitioned into medicine. I was a researcher, Howard Hughes, and I love asking, but why? But why? And with limbic retraining, it calms down those people who are so sensitive, get you kind of out that fight or flight. And in a sense, some of my patients don't tolerate any form of treatment, may that be homeopathy, herbals, meds, until that limbic system is retrained. And so I've been looking into Gupta for years. Of course, Annie Hopper, I prescribed, did I consider it a prescription? DNRS is a prescription because it's mandatory. I just had a patient this week and I was like, okay, you must do Primal Trust. I try to find out what the patient's like, what their personality is. So a lot of my younger patients have preferred either Gupta or Primal Trust. Definitely Primal Trust because that's one of the newer ones that I actually just out of curiosity did, and I loved it because I kind of want to see who can I recommend this to? I know someone is really cognitively impaired or really anxious. Which one is going to be tailored to their needs, right? But it is fascinating. And sometimes I will tell patients, don't get disappointed. You must do DNRS before we start treatment. And another one I use, especially with another program I found helpful with my PANS and PANDAS kids, and even some of my chronic infection cases, is Safe and Sound.
From Dr. Stephen Borges.
Yep, I love that as well. That's another one. So anything you can do that's not oral, right, that can help retrain the brain is very beneficial. And I have seen benefits both in research. I know Dr. Amen, we have a lot of research, especially in EMDR and brain scan and changes that you can see with that deep limbic system. And I know Dr. Gupta has research as well on just the impact pre and post in his paper. I mean, it's real and it works if you're committed to it. Now, it does take commitment. That's the thing. But you have to be committed to the process. It's so helpful in so many people.
I'm going to have to change the graphic for this episode to say Eboni Cornish ND at this point, because I think you've just really gone over the edge now with some of these things.
I don't know about that, but I was maybe put ND, MD, maybe possibly wannabe after it.
It's been a few years now since we did our conversation on Morgellons, and I'm just wondering, in the few years since our conversation, what has changed in the Morgellons landscape? Any new understanding, any new treatments that have emerged that really have become a focus for you? What's different now as compared to when we had that conversation?
I have found so much different as a way of my approach. I've seen a lot more, I would say, honestly, I have about majority, a lot. It's probably very rare that I'll find a Morgellons patient that doesn't have mycotoxin or biotoxin illness. I think there's an association there. I think research needs to be done. If I didn't have triplets, I would do it. But, there's definitely an association with biotoxin illness. I've been using a lot more methylene blue for my patients with mycoplasma, a lot more loricidin, because I'm seeing a very high associate that I didn't know before with candidiasis in my Morgellons patients. So I'm using more antifungal, like that's been a mandatory component. Yes, the antiparasitics can be helpful, but those antifungal, both herbals and pill form, that's like mandatory. So those are the big things that have become different for me, like just routinely with the home testing and mycotoxin testing, the not missing the candidiasis, which I think is key in so many Morgellons patients. I mean, I had one patient who, like I always say, you treat Morgellons like you treat Lyme, right? But now I'm like, you treat Morgellons like you treat Lyme and candidiasis and mold all together in
And
one,
Bartonella, yeah.
Yeah, but the yeast and the mold piece, has really changed my practice, and also incorporating methylene blue for these patients as well is something that I've changed over the last 2 years.
I know that Ginger Savely has in the past commented that some of the best interventions in Morgellons are those that also treat Bartonella. Is that in part why you're using the methylene blue, or are you using methylene blue for another purpose in Morgellons?
Yes, I'm using methylene blue for the Bartonella coverage. So in Morgellons, I found some of my best protocols definitely include the antiparasitics, but incorporating things like dapsone and rifampin and methylene blue, and of course leucovorin with maybe some doxycycline, and then like a anti-helminth of my choice there, and an antifungal, either natural or herbals. But yeah, that methylene blue with that Bartonella coverage. And, Ginger is one of my mentors. She's the one who really got me started 10 years ago in Morgellons. But that's something that's key. Like that methylene blue, if they're not on antidepressants or SSRIs, I try to make sure if I can incorporate it, I do incorporate it for that population. I've been very happy with it.
My last question is the same for every guest, and that is, what are some of the key things that you do on a daily basis in support of your own health?
I was not looking forward to this question because so many of your people, they're so smart. They're like, I do this. I do not practice what I preach in a lot of ways. Like, yes, I eat healthy, don't avoid the junk, take care of my brain, take my supplements. But I have to be humble as a doctor. I have terrible self-care. I tell my patients all the time, make sure you use the sauna and the bath and you meditate. Man, I guess my self-care is treating these patients and just feeling so happy when they get better. And then being with my family, because, having 7-year-old triplets, they're so funny. They made a video of me, like they imitated me one day on a video, just talking about, I don't know what they made up. It was something on Instagram I said about the gut, and they made a video and it was hilarious. So things like that, that's my self-care. Just being able to know, you know what? I'm here for a reason. People are getting better. Yes, it might be stress. Yes, it's this. I'm not a workaholic, but I need to do more self-care. And I was not looking forward to that question, but hey, I'm real. I eat well, I take my supplements, I do some exercise. But as far as the all nice things I tell my patients to do, if you're listening, I'm sorry. I don't use the sauna like I should, or take an Epsom salt bath. I apologize.
I do think, though, that living in your purpose and your passion is probably one of the most healing things that you can do. So,
and your faith, because I think, everyone believes, but I'm a Christian, and I believe that I was brought here for a reason. It's just like, this is what I was designed to do. It's not easy medicine. There are a lot of sick patients. There are not a lot of people who can do it, but that dedication alone is my gift. That's what God's called me to do. Because hey, I don't even know how I got in this field in the first place. I didn't mean to be here. It was, now I'm talking about being an MD, ND, but it really is every day looking at that patient who's been dismissed or abused. Like I say, they come in so abused by other doctors. It's really a blessing when you see those stories and those testimonials. And it's like, if I don't do it, it's not a lot of us out there that will, So that is my purpose here. And that's scary to say, but it makes me happy. It does.
You are doing great work. I'm just so honored to know you and to have connected with you over the years, and always excited to see what the next thing is that you're going to do. I appreciate that you spent a lot of time with us today talking about toxoplasma, but even beyond that, just really want to honor you for living in your purpose and your passion and helping to minimize the struggle and the suffering of so many. I just think you are incredible.
Oh, I thank you so much for having me. It's an honor. And you are living in your purpose as well. Don't forget that. You're entertaining us. You are shedding so many complex illnesses to light. Your podcast, it should be rewarded because you're one of the only people who are really doing it. You're getting evidence-based experts, everyone I know and love who's on the front line, just to educate people for free and bring it to the masses. And you've been doing it for such a long time. And sharing your story and being vulnerable to listeners. I'm not saying this just because I really do admire that and what you do for these patients, and you share your journey because it helps. I have patients who listen to you and they'll bring up things like, did you know? So I'm like, where did you get that from? Like, oh, maybe I do need to listen to that, because you're doing great work and this is your calling and you do an amazing job at it. You do.
Thank you so much, Dr. Cornish. To learn more about today's guest, visit amenclinics.com. That's amenclinics.com. amenclinics.com. Thanks so much for listening to today's episode. If you're enjoying the show, please leave a positive rating or review, as doing so will help the show reach a broader audience. To follow me on Facebook, Instagram, Twitter, or TikTok, you can find me there as Better Health Guy. If you'd like to support the show, please visit betterhealthguy.com/donate. To be added to my newsletter, visit betterhealthguy.com/newsletters. This and other episodes can be found on YouTube, Apple Podcasts, Spotify, Google Podcasts, and Amazon Music.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.